pleasure to be here. I don't know how many people actually know what an anesthesiologist does. Can you raise your hands? Well, that's pretty good. So when I go from place to place, I usually don't get permanents like that. People are wondering what anesthesiologists do, and we had the same struggle when we were in training. So we sat around one day when things were a little slow, and we decided what's a good term for us to use so people can rapidly know what an anesthesiologist is. And we came up with the term medical ninja. And we thought it was pretty appropriate because we're highly specialized, we're dark and mysterious, and we're the last thing you see before you lose consciousness. So, Indigenous health is an interesting part of health. I've had the chance to participate in surgical transformations across the province of Saskatchewan. I was lead over the measurement and evaluation piece of patient-centered care when it was implemented across Alberta a couple years ago. But for some reason, Indigenous health, we always approach it as being such a high level of complexity that it's nearly impossible to ever unwrap. As a trainee, I participated in a three OR swap for transplant. That includes more than 30 healthcare professionals, multiple different flights, 3 organs that really need to get to where they need to go at the right time. Very, very tight timelines, but for some reason we do that over and over again, but we can't figure out Indigenous health. So what I'd like to get across to you today is maybe a different frame for you to look at things, and maybe a different opportunity for you to see the problems in a different light. I'll warn you ahead, I'm only going to go through half my presentation, then I'm going to deviate, because I want some time for questions. So key questions that we usually ask in any area of complexity is asking what kind of impact have we had, how do we leverage existing resources to achieve our outcome, and how can we make an impact with this new knowledge and these new resources. So for Indigenous health, there's quite a few facts that I think we need to agree on. The first is that the most significant health disparities of any demographic in Canada, both absolute and relative, are present in Indigenous health. Whether you're talking about opioid abusers being 17 times more likely to die in BC, if you're looking at absolute rates of HIV in Saskatchewan at 200 to 300 times more than the national average, which is multiple times worse than even the worst location in third world countries. Or you're talking about diabetes prevalence, where 100% of some communities all have diabetes. Indigenous health disparities are among the worst that you'll ever find in any demographic. If you're looking for a place to have impact, this is definitely the place. Since the release of the TRC, both governments and healthcare organizations have really doubled down on making sure that they did something, or at least said something about having impact in this area. But when we look at actual outcomes, the digitization of health, both when you look at it from an informatics and a clinical point of view, we actually haven't had much, if any, impact. Every time we talk about Indigenous health, and I've participated in things at both the federal, provincial, and local levels, we talk about these small groups of 40 people where they all got transferred onto electronic medical records. Or in BC, 3 communities that had 800 people all transferred. These are the successes that we're grasping onto. And when you look at it in a relative point of view, these actually aren't really successes at all. Before I go any further, I'd like to introduce a concept. So for those who have a bit of a medical background, scotoma may be a word that you come across before. But it's a medical word that represents a blind spot. So quite literally, when you look around, you have an area in your field of vision that you can't see things. So scotoma doesn't just include physical types of limitations as far as blind spots. It also includes cognitive ones. And I'm going to go through an exercise here just to see if I can tease out some cognitive blind spots with you. So this is a very simple exercise. There's no trick, all right? I'll say that up front. I just want you to count the Fs in the next paragraph. I'm going to give you 3 minutes and just count, or 3 seconds, and I'm just going to have you count the Fs, okay? So I'm going to count out loud, just count the Fs. So you have 1, 2, 3, finish counting. So how many were there? Before anyone yells out, I'm going to ask, all right? So how many people saw 3 Fs? Can you raise your hands? All right, how many people saw 4 Fs? Raise your hands. How many people saw more than 4 Fs? So proportionally, you're actually pretty close to how people actually see this. So there's actually 6, all right? Now there's 2 reasons why less than half of people see 3 Fs, and then about equal amounts see 4, then very, very few see more than 4. It's because of the way that we're trained in school. All right, so by the time that we get into grade 4, most of us, when we read, tend to read auditorily in our heads. So as you're reading through the paragraph, you're sitting going, finished files are the result of years of scientific study, et cetera, et cetera. So the ofs in the paragraph sound very different than the scientific parts, all right? So that's the first cue. We read auditorily. The second is that even though I told you to count the Fs, many of you were probably reading for content. All right, you wanted to know what the paragraph was about, even though that was not the task at hand. All right, so you tend to skip over small words in order to get the content in the limited period of time that you have. All right, so I'm going to have you go through one other one. I want you to count the triangles, okay? There's going to be 3 triangles up front. Just read 1, 2, 3. All right, maybe I can get a volunteer here. Who saw 3 Fs again? Raise your hands. It's a lot less than they had before. Can you help me out? Yeah, what's your name? Megan. All right, you sound like you have a very loud voice, right? Can you yell for me? Can you say, hello, my name is Megan?
Hello, my name is Megan.
Perfect. So I want you to read the triangles in that loud voice, okay? And just go quickly. I only have 15 minutes to present, all right? So we're going to start 1, 2, 3, 1, 2, 3. All right? Ready? Okay, read the first one. Next one.
Bird in the hand.
Next one.
Once in a lifetime.
Is that what they said?
Yes.
Just take a minute. Read them through again. So I presented this across the country more than 100 times. And inevitably, people don't see what's in the triangles. I just told you that you weren't going to see the things in the triangles, right? So even immediately after, we're told that certain things we don't see, we still don't see them. And the reason why is because these cognitive blind spots, these scotomas, are so powerfully ingrained in our minds that they're hard to work around. I'm sure all of us have been in committee meetings or had opportunities within our companies to work with teams, and you're just sitting there going, why can't you see what's right in front of you? All right? If you trace back people who this works with and people who don't, if you have people who've never gone through grade 6, left school before grade 6, you can't trick them with these. Also kids, you can't trick children. All right? And the reason why is because these two groups of people reliably never develop these cognitive blind spots that we talk about. So there's this world out there that we don't see. And these things aren't just for, task-type oriented things where we talk about reading. They also include things like social interaction, institutional structure, things that we just can't see. So we scotoma and profile in medicine every day. As an anesthesiologist, I'm looking across the room. I can tell you who will probably be a difficult intubation. I know that already, right? I could tell you who will probably be a difficult IV start. I know who I'd probably pull out the Levofed for before I even put you off to sleep. All right? Those things are practical, right? Profiling is practical to a great degree. It's integral to the work that we do, and it's probably integral to the work that you do as makers and creators in the area of digital health. It allows us to streamline work, to jump towards doing something instead of waiting and analyzing. Now, profiling, though it's practical, happens at a fairly scary and fast rate, 18 seconds. So since the 1980s, we've seen studies that have come out of Ivy League schools, Ivy League medical schools, that have shown over and over again, within 18 seconds, your healthcare provider tends to interrupt you because they've already decided what you have. And to a great degree, if I'm being completely honest with myself and how anesthesiologists work, I only have 10 minutes to actually figure out what's wrong with you to begin with, so I gotta go fast. So a lot of my discussion with you isn't necessarily finding out what's wrong with you, it's me asking the question, is what I think is wrong with you, what's wrong with you? All right, we call that the working diagnosis or gut feeling. So with digital health, we also have certain things that I think you can liken to gut feelings. Expectations for system parameters, expectations for norms of bandwidth, system requirements, people's familiarity with the type of technology that you're using, expectations for health infrastructure, as well as expectations for the common health problems that you're addressing. Now, the question is if we're unsuccessful in Indigenous health, if disparities continue to get worse, there must be something that we're not seeing.
Yes, I have experienced racism in our system with the doctor here and nurses. Nurses treat us differently. My file, every time I go there, like, I'd be there before everybody, and I thought it's first come, first serve. But my thing would my file would get put to the bottom. I'd have to wait there all day, and I'd be trying to talk to one of the nurses or talk to one of talk to the doctor, then, they tell me, go sit down, like telling me to go sit down like a child, I'm not a child, and then not wanting to speak to me, and then I see someone goes up right after me, like another patient, and they talk to one of them right away, and like they tell me they're busy, and that's with the doctor and nurses that they do that. Well, for one thing, I'd like a different doctor, plain and simple, a different doctor, and also better training for people skills for the nurses. They seem not to have any people skills, They get grouchy at us. The woman that sits at the desk that takes some names and, sets us up, she gets grouchy with us. When I was there 2 weeks ago, I heard her swear and say, effing natives. I heard that. I was sitting right there in that chair. She kind of whispered it, but I heard it. I heard it clear enough to make out effing natives.
Well, I know when my mother was in the hospital, she had diabetes and she had, like I said, heart, kidney, and lung problems, and she was in the hospital for about a month or maybe even 2 months. And when I went to visit her, she didn't have no sheets on her bed. They told me that she was on a mattress that didn't need sheets, but when they finally came to check on her, it was not that kind of mattress. And my mother wouldn't say anything. She wouldn't make any kind of fuss. She just laid on the rubber mattress, and that's it.
I'm a diabetic, and the one you're talking about, he likes touching women. He even done that to me too. And I used to wonder, is that possible for a doctor to do that? Eh? He slipped his 2 hands into my panties, but didn't touch my private. He done that from the back to the front. Eh? Boy, I was amazed when he just threw himself on the chair after he done that. And he was just blushing, just red. Eh? I just about swore at him, but then again he might charge me. I should have swore at him at the time. I tell him the same thing what I experienced with him. Are they going to do anything about it? Like that. The time I broke my knee, and then when I was there for 5 days, and the nurse was coming to give me 4s, and then I told her, can I get a Tylenol extra strength instead of it? She got mad at me, and she went back to the where she keeps her pills to come and give me that Tylenol thing. And she holds my lips and then puts that pill into my mouth roughly. And I told the other nurse to put my leg on that pillow. She lifted my leg, put the pillow there, just dropped my leg. I was just being treated. If I was able to walk, I said I would have walked out of there. And I told my auntie, though, she gets the same treatment.
Well, a lot of old elders don't feel safe there. I see elders when they're in a hospital. Like when I go up there from that time, I talk with them. They don't feel safe. They look scared, but they don't want to say anything. But they look scared, and you can feel that on them. And that shouldn't be these are our elders. They shouldn't be feeling scared like that. That's a place they should feel safe.
Kinds of things should happen. We should have proper diagnosis. We should have First Nation people at the doctor's office, the drugstore, throughout the system there. We should have a place for concerns to be heard, anonymity, and also online questionnaires or something to that effect where a person can actually just sign in and say this is what happened to them.
He's the only doctor we can see, so what if we're really sick one time and he doesn't want to give us treatment because of that? And he will do that.
And that nurse there, that receptionist at the hospital, she used to be very friendly with me. Now and mud to her, I guess. For what, I don't know. You should see the way she treats them, eh? Very negative and looking angry. I just about told her the last time, why don't you quit your job if you don't like working for Indians? I just about said. I will do one of these days.
So that's not an easy video to watch. It's not easy at all. How many of you know that this happens? How many of you actually sat down and talked with patients about it? Until we sit down and actually get to the core parts that we gloss over, we're too focused on efficiency and efficacy with the assumption that the system's working. How many of you, when you first started, you're creating in whatever space you're in or trying to find new directions to go in your different digital spaces, sat down and just immersed yourself in the environment? Sat down with people and listened to their stories, both the good and the bad, got the complete story of what was going on. How many of you actually done that with Indigenous communities? And how many of you are finding that you're moving forward and finding some success? So one of the things that we found, and we started with a small group of 3 of us. I got invited into 3 First Nations in southeastern Saskatchewan, and they asked me to answer a question of why were their communities so sick. And we quickly realized that we were asking the wrong questions after listening to these stories. The question wasn't why they were so sick, it was why was everyone else so healthy? You know, why in the situation for an Indigenous patient do they worry that if they're sexually assaulted in a physician's office, that they'll be the ones thrown in jail? Why do they sit and ask, you know, the person's being openly hostile and avoiding me. I have no other ways to go. This is my only chance at health. You know, there was a saying by an elder early on in our research that started about 4 years ago, where he told us, you know, our stories are here, we're ready to share them, but no one's ready to listen. And people aren't ready to listen because they're hard stories. It's hard to hear that this sort of thing isn't uncommon. This is the shared experience of Indigenous people across the country. You know, at the peak in our project, we had 150 First Nations involved. And this was the common experience. And it's common enough that we were able to form a narrative. And from that narrative, we've actually been able to gain incredible traction. I actually think because of the work that we did was one of the reasons why the Ministry of Health is reallocating Indigenous services. You know, we've been working with Minister Philpott since 3 years ago on this. You can hear in her speeches that a lot of the language that we used 3 years ago that was just too incendiary and difficult to approach, she now includes it as things within her speeches. Things like the status quo is no longer an option. The system isn't broken, it's working exactly the way that it should. So I'm going to share you that story, and I'm going to step back for questions, because I think you need to understand the story and see where you fit in. So this is the story of Indigenous health. There's a crisis, but it's not a new crisis, because these crises happen in our communities over and over again. They happen so much that our systems have actually broke down. We're just running from one crisis to another. That's our healthcare system. But sometimes these crises, they get to the level where they break the national consciousness. I'll use La Loche as an example. You know, a horrible situation where shootings happened, mental health obviously wasn't provided in the way that it should have. Communities were broken, the town was devastated. So because of these crises getting into the national consciousness, people who are stakeholders around the table, decision makers, all descend on the communities and say, we need to meet. And we need to meet because we're going to come up with some solutions. And those solutions are going to lead to impact. But what happens? Crises get worse. If you go back to La Loche now, the only sustained change that has happened is there's now a metal detector at the school. That's it. There's no more mental health services. There's no more attention. They still have the same problems that they had before. So as someone who works through algorithms on a daily basis, one of the things I was taught early on in training is if what you're doing is not working, it's obviously not doing what you intend, or you're using the wrong thing. So we asked the question, is there another story going on? And this is what we found, and we validated it with the First Nation communities that we've worked with over the past 3 years. Between the crisis happening and these meetings occurring, there's actually things that we call side conversations. So side conversations are conversations that exclude the people that you're trying to impact. You know, discussions between ministries and their health regions, discussions between the federal and provincial government, discussions between colleges of medicine and the federal government asking, you know, can you come up with solutions? Now, these side conversations exist in all sorts of our treatment streams. We all know that we don't always include the people that we want to impact in our discussions. But they do start to go sideways when they lead to resource allocation that happens before the solutions are actually chosen within these meetings with communities. And this is repeatedly what happens in Indigenous health. Side conversations happen, resources flow out of the community, and that inevitably leads to outside implementation. All right, in La Loche, what happened is that millions of dollars was allocated towards the University of Saskatchewan to find a solution to these problems, even though the University of Saskatchewan knew full well that it didn't actually have people in the community who understood the problems. So you can see that if you have these two stories, these inside and outside circles happening, it actually makes a lot of sense why the system remains broken. So we then asked ourselves the question, if you have this inside circle where community is sitting and patients are sitting, and you have this outside circle where all the resources are flowing and none of the impact is occurring, do we have to get rid of this outside circle? Do we have to minimize it? What do we do? And what we actually found was surprising to us. We discovered that the outside circle is an integral part of healthcare. It's just something that's always there. Communities and patients don't always have the capacity to fix their own problems. The issue is if the two aren't aligned. If these crises don't lead to discussions and side conversations that inevitably feed back into the meetings, that then lead to resource allocation where everyone's on the same page, where monies, physical spaces, human resources, and knowledge resources are flowing, that then lead over to implementation that includes all partners, and then impact and decreases in crisis. So it's the overlapping of the circles that's important, making sure that people are all on the same page when it comes to the different parts of the story. The second question that we had is, who in the world would ever create a system like this? And the answer to that is actually in the history of colonization. So Murray St. Clair has a really great quote where he says that the intent of colonization was actually to extinguish the right to Indigenous people to land and resources. That was the only reason. So when we talk about residential schools, when we talk about the current Indigenous health system, when we talk about the child welfare system, all of them make sense if your original intent was to weaken a nation so you could take their resources. So if you use these things as a frame for when you're building solutions and understanding problems, what we're actually talking about isn't creating more efficient patient streams, because the system's set up to not actually provide the kind of care that people need. The solution is focusing on power differentials, making sure that people in the middle are able to impact people on the outside, and that protective mechanisms are in place to make sure that people on the outside can't oppress people in the middle. Now, this is very similar to the same sort of situations that we have with patient-centered care. Exact same dynamic. How do we shift power towards the people who should have power? How do we make sure that patients are at the center of their care? How do we make sure that everyone's aligned and moving forward on the same page in a way that the patient leads? It's the same issue that we had with quality improvement. We asked, how can we improve systems, making sure that people aren't able to hide behind their mistakes? So these are not new concepts, but for whatever reason, and it probably lies in the historical relationship between Canada and its Indigenous peoples, it's been very hard to see. So if I was to stand here and tell you, how can you make an impact in Indigenous health? How can you change your unsuccessful solutions into becoming successful ones? Recognize that what you're really trying to do is provide something for patients that you haven't done before. Can you go back up to the slides just for a minute? I don't think that's a slide. There we go. Oh. No. All right. I remember the slide. So it's making patients visible. All right? Making sure that they're not forgotten. It's making sure that we have minimal data sets. I'm not sure if any of you know this, but there's absent data sets that are actually required by law in most provinces that just don't exist for Indigenous peoples. We don't even track mortality data in most communities. We've had an opioid crisis in Saskatchewan that's had people dying in communities 2 or 3 times a week, literal caskets coming in and out of communities. And I've been there at these community centers where this is happening. None of that has been tracked. You know, this statistic of 17 times higher death in BC, that's been known by communities for years. But because there wasn't anyone in the Ministry of Health that was able to validate the data and people just weren't listening to patients and their stories, we glossed over what was happening and we ignored a crisis that's been there for years. It's making sure that patients are in control of what's going on. It's making sure that we bring quality improvement and safety into these communities. And in the end, just making sure that we equally apply the same rules that we expect for everyone else. If you sit down and actually dig deep into Indigenous health, if you sit and listen to the trauma that these people share, you'll realize that the set of rules that communities are expected to follow are so outside of the norm of what we expect people within Medicare to follow, that it's no wonder that our solutions don't work. The solutions are out there, I guarantee you them. You know, we went from being a small group of 3 to winning an award from the Prime Minister last April. We did it with minimal funding and just with sharing and understanding stories. This is not complex, it just hasn't been done before. And this is the opportunity for you here. So I'll open it up for questions now.
Hi, my name's Amy Pack, and I work for a health standards organization, and I really appreciate the talk you just gave us today. Your work and the message you just shared with us is very important, and it's good for all of us to hear, and it especially applies to me in a context of developing standards where we're trying to communicate with Aboriginal people to have their input better develop the standard to address the real issues. However, we're having pushback and we're having difficulty reaching these communities. And I was wondering if you have any solutions to addressing these trust issues sometimes that are relevant.
So early on, we looked at how people normally interact with Indigenous communities. And one of the things that we found is that everybody wants to convene. If you sit down with the organization, the very first thing they say is, let's have a big group session, we'll bring everyone together, we'll be the sponsor, we'll fly everyone in, we'll have a good discussion. But what inevitably happens at those discussions, and I'm sure you've been at them as well as lots of people in here, is that you get around the table, you start unpacking problems, and then someone stands up and goes, if only we fix maternal health, all of our problems would go away. Then someone else stands up and says, if only we had electronic medical records, all our problems would be solved. And you have a competition then around the round table of special interest then trying to get momentum from around the table to say, you know, this is what we want to do. Most Indigenous health solutions are selling points. They're not definitions of the problem. We take electronic medical records and we say, take this community, this will fix your problems, when in reality, they only get a doctor twice a month. They don't have basic access to medical care. There's not even a clinic. Where are you going to put the medical records? You know, so sitting down and really taking the frame where you're just listening is probably the first part, and focusing on really getting clarity on what the problem is. All right? There's a phrase that was told to me by an elder that we met in Saskatchewan. He said, you know, the difference between a consultant and a facilitator is that the consultant takes all the information that they hear and they distill it down into what they think should have happened anyway. A facilitator, on the other hand, takes all the information and reflects it back in a clear way, makes it understandable for a community to understand. The trust issues come from the story that I told you, where communities are just waiting for the shoe to drop, where that partnership then leads to the other person getting all the resources, whether it's fiscal, human, physical, or knowledge. All right? If you approach it as just defining the problem, that'll help overcome a lot of the issues that you're running into right now. It takes a while for people to actually trust that that's what you're there for. I know it took us about 1.5 years for people to get to the point where they said, you know, you're actually just interested in listening, you're not here to tell us what to do. But the second part is that the nothing without us phrase that is so common now has actually become very disempowering, where people don't claim their power anymore. You know, often standards organizations stand there and say, we can't tell you what the standards are, you have to tell us. Well, how could they know? They're not a standards organization, right? They don't have the expertise within their community. They don't understand the legislation. They don't know what's required. They don't understand the different value streams that you have to kind of align to make sure that things are implemented. Own your own power when you work with communities. Be very clear with them about the value that you provide, and don't be ashamed that you have expertise. The TRC has been less effective than it could have been because people have almost become ashamed of the positions they hold. Whether the community respects you as a standards organization or not, you're still a standards organization. You still set the rules. You can't take that away. As a physician, if you come into my OR, it doesn't matter if you respect me or not, my drugs are still going to work on you. I'm still going to put you to sleep. I have to own that, right? And let the relationship build and the trust build. Yeah, next question.
Yes, Chad Dickie. I'm from the Fort Nelson First Nation in northern British Columbia. In my lifetime, I can count 65 deaths that were preventable and avoidable, and that's in 55 years. So from my very first memory. So I challenge anybody in this room to think of 65 people that they have known and talked to and encountered in their life that have died. I challenge you to see what number you'd come up with. 65 in my lifetime. What I was going to what I want to address in part of what you're addressing is the social determinants of health. How can we better align some of the distal and the proximal things that happen to improve the Indigenous access to health, but also empower First Nations people to recognize the fact that they can contribute. They have the power, they have the right to ask questions. The last thing I wanted to ask was, part of the thing was maybe digital health can help with developing tools or data capture for engaging First Nations people to build up those numbers, because there's lots of information out there. It's just not specifically targeted to First Nations people and populations. And I still have a real challenge with people in Iqaluit, people in northern Saskatchewan, people in Nuvik. They don't have the digital access that we have down here. And that's a big point for me, and I think it's a big point for you as well.
Mm-hmm. Well, thank you very much for that. I guess I'll go through your questions in sequence. So thanks for sharing that about the deaths. I'll share a quick anecdote. When we were unpacking the way that death reporting happened in Northern Ontario, one of the things that we found is that the cause of death was actually defined by whoever the first responder was. So if it was an EMT, they'd identify it. If it was a police officer, they'd identify it. And what they'd say would be whatever they were told. So when we talk about preventable deaths, a lot of times if someone had an asthma attack and then didn't get Ventolin because the Ventolin wasn't stored or updated for the past couple of years, the cause of death was defined as something different, but it's because the person doing the assessment didn't actually have the medical expertise to define what it actually was. So the reason why we don't know about these things is quite literally because we don't follow the same sort of processes. There's no coroners that travel up north. A lot of times the medical certificates are signed off by people who don't actually understand the way that people die, outside of very superficial ways. So that's the first point. Second point about the social determinants of health, I think it's a fabulous frame for how to solve things. The problem is that it conflates everything, all right? So we know that water is important. We know that healthcare access is important. We know housing is important. But what happens when we work through things in Indigenous health, welfare, education, et cetera, is we throw everything in a bucket, we shake it up and say, let's find a solution. It's impossible to do that. You can't mix the social determinants of health together and figure out how to fix all the social determinants at all. It's an impossible position. But the way that we've reasoned our way out of it is we said it's going to take a generation for us to change. Now, for those of you who work with data sets, if I'm telling you that everyone in this room is sick, and it's going to take a generation for all of you to get better, quite literally, all of you will be dead. Nothing will change for you. All right, and that's the frame that we've gotten caught up with the social determinants of health. In the mainstream, when you look at ministries of health and health regions, for example, we have a federal department that's now shifting over to Indigenous services that was tasked with both doing the Ministry of Health job and the health region job at the same time. Imagine how chaotic that would be if that was the way that you operated provincially. Not only are you figuring out how much dollars you're going to spend in an area, but you're actually choosing which programs you're supposed to do at the same time as choosing outcomes based on your measurement. You know, there's lots of baits and switches that happen at the federal level because we conflate these responsibilities. You know, it's drawing clear lines between housing, it's drawing clear lines between education and water, et cetera, separating the discussions and then having those deep conversations. The social determinants are a good way to frame, they're not a solution for. You know, it's the same thing with, you know, different types of rating systems that we have for sepsis. They tell us how sick someone is, but the solution of how to actually make them better lies in the story that brought them there. And I can almost guarantee you, down to a community, that communities know how they got there, and if you listen closely to their story, it'll be clear how they need to get out. As far as the third question, digital health and the problem with remote communities and their access to broadband, I think there's both high-tech and low-tech solutions to things. When I was talking about assumptions that we often make as makers and creators in the digital space, you know, there's satellite balloons that are being used now, Wi-Fi relays that you can take when you're hiking, just leaving a relay along the way so you can bounce signals. There's all these different solutions. There was a comment made by a physician that I talked to in Ottawa a couple years ago where he said, you know, cell phone towers are a way of jumping over the existing infrastructure that used to be there, but it's now obsolete. We don't have to lie down cable. We can jump down to the next solution. We can leapfrog into the advancements that we have already. We don't need a stepwise approach. We can just jump to what's best. And that's both the best thing and worst thing about Indigenous health. There's not a lot of rules there, but that means that we can create our own.
Hi, Victoria Lee from BC, Fraser Health Authority. Thank you very much for your very powerful talk today. I have a question for you in terms of areas that we're struggling with, and would appreciate your advice in terms of approach. What we're finding is that what you mentioned in terms of racism is also compounded by the fact that Indigenous people are overrepresented in homeless population and also in populations that suffer from substance use. And stigma for those population groups are quite significant in our healthcare system. So when we see care that's not optimal, what we find is that that kind of stigma is actually impacting how we're providing care, even beyond racism. So, and it's again compounded. And what we hear from the healthcare provider side is that you know, there's compassion fatigue, and often the encounter is through our emergency departments most frequently, and the kinds of scenarios that they describe are that, you know, these populations come into our emergency departments very often and they're frequent. They don't necessarily require emergency department services. They don't need to be there. Therefore, they're kind of ignored, avoided, to the side. So my question isn't, it doesn't justify how we're providing care, but how do we actually tackle that complexity of our providers and provide support in a way that's going to change that interaction? Mm-hmm. And then I have a second question as well, which is, in BC, of course, with First Nations Health Authority and provincial work on cultural safety and humility, we have quite a bit of online support and training that's available in this area. But we've recently had conversations about how having discussions and training around cultural safety and humility are quite different than having discussions and training around racism. So I'm curious about your thoughts around that as well. Mm-hmm.
So I'll try and answer both those questions at the same time. So for those of you who are in the room, probably very familiar with cultural competence, the idea that if you educate someone about another other, that it will lead to a change in behavior. Cultural competence is healthcare's great failure. All right, I don't think I've come across a jurisdiction where cultural competence has actually made any measurable change. And the reason for that actually lies in the way that health providers work. If you sit there and educate me that using, you know, saline versus Ringer's lactate is better or worse, I'm actually not going to change unless it's more convenient for me to get the one that you want me to use. And there's been lots of studies that have looked at this where all that you have to do is change the shelf that Ringer's lactate is on, and suddenly everybody adopts Ringer's lactate at the same time. So people do things based on habitual structural things. You know, they look at behaviors that are normalized, right? When you talk about populations that are kind of pushed away and don't receive care, what you're literally talking about is denial of care. Denial of care is actually a reason to lose your license. But we frame it in a way that is socially constructed to be acceptable. Right? Now, I'm not saying these are bad people, don't get me wrong. I'm not saying for a second that any of these people that are there are not people who mean well. I don't think any one of those emerge docs goes there to work and says, you know, if I just reject Indigenous patients, totally gonna make my weekend. You know, I don't think anybody does that, all right? But we've normalized these behaviors. You know, when you look at the way that we respond to Indigenous issues, I think it's very important to normalize what should be normal versus making the abnormal normal. Right? Denial of care in our healthcare system is not normal. Right? It's completely not normal. So when we have a situation where denial of care happens, we have to treat it as abnormal. So that would be my first suggestion, is making sure that the people within the system understand that this is not a normal response. Can it be explained through compassion fatigue? Absolutely. And compassion fatigue is a real thing. You know, I experience it personally. I have colleagues who experience it. But it's not an excuse for denying care. All right? So that's the first part. The second part is that when you're looking at ways to intervene, the end goal is to get people to change their beliefs. It's not to educate them. So it's a very good point when you talk about cultural humility versus cultural competence, because you actually have a continuum where you go from ignorance, cultural competence, cultural safety, where people can access environments that are free from hostility, then cultural humility, where you sit back and say, you know, I may not understand where the patient is coming from, but they're the most important part of this care interaction. I need to step back and make sure that they understand. Now, from the opposite side, these patients are probably coming from hostile environments, right? So they've been sensitized to react to your emergency docs in a very, very violent and aggressive way. If you look at what's been normalized in our communities, getting rejected from care, having things taken away from us. If you know, you get the wrong person upset, you get care literally withdrawn. Not getting the same sort of medications, whether it's through NIHB or other types of pharmacare programs. All these things have been normalized. And so patients come into these environments with a whole lot of anger and a whole lot of hostility. And all they need is for someone to look at them the wrong way and they snap. But it makes sense in the context of what they've experienced. So when I sit down with health regions and I talk about how do you unwind these things now, there's two sides that have to be unwound. There's the side that comes from the health provider side, but then there's also the community side. Right? People need to realize that a change is happening. And sometimes you just need to create forums where people can get their yelling out. You know, I remember sitting down with a patient who was coming for back surgery, and there was just something off about the discussion. So we're going through pre-assessment, and I'm asking about his pain and all these things. And then I asked, do you really want this? And then a big explosion, a 10-minute yelling session where they yelled at me that as the health system, they were mad at me that I was making them have this, and who are they to say whether or not they should have the surgery, and why are they being forced into this, and all these other things. And I kind of let them unload for about 10 minutes. And then during a pause, I said, you know that it's your right not to accept this care, right? And at that point, the patient actually started crying. And they said, my surgeon told me that if I don't have the surgery, I'm never going to get surgery ever again for any problem, and that they're going to charge me $500. And I don't have $500. So from both sides, it makes sense behaviorally, right? It makes sense from the compassion fatigue and the fact that a lot of patients who have restricted care or have had poor care in the past explode on these physicians, and that the healthcare providers are sensitized, right? They're expecting this to happen, they're dreading it. But it also makes sense from a patient's side that if they're caught in this environment or constantly they're exposed to hostility, that they react this way. So the solution, I don't think, is the online training, although that's part of it. I think the solution is unwinding these things from both sides and understanding the perspective that they're coming from. Does that help? All right. Thanks for that question.
Okay, this is our last question. Good afternoon, Dr. Lafontaine. Thank you very much for your presentation. My name is Margaret Carregard, and I work with the Siksika Nation. I've worked there for 27 years. And in the last probably 15 years, I've been working between a diagnostic technologist, a clinical services team leader, and health informatics. And so it was interesting. I've listened to this, and it was very profound, the amount of, your people that were discussing the healthcare system and how it fails them on a continual basis. I have been doing a project through the Health Services Integration Fund within Alberta for e-health for First Nations communities in the last year with a very small team. And it's been interesting to watch how, when I reach out to partners that we've identified and they said, yes, we're partners in your health, we'll help you with your project. When I go to talk to them, they don't know how to come in and work and to make things work within us. And it's like there are a lot of barriers that come up. We don't work for Alberta Health Services, so well, we can't help you then. So those kinds of things have to be addressed as well as we move along with digital health, because those jurisdictional issues are very, very real when it comes to First Nations health and working with communities and working with the province. And I think that those are some of the things that need to be addressed as we move forward.
So just to extend to that comment, jurisdiction is a myth. There has not been a single court case in Canada that's been successfully won that's denied care to First Nations on the basis of jurisdiction. Jordan's Principle is actually the most recent case, and I think it's actually the only case in Canada that's ever challenged jurisdiction in health in this way. And they actually won, where within 48 hours, the government, no matter who requests the service for children, has to respond within 48 hours. So this idea that jurisdiction exists is actually a big myth. It's a myth that we've all been taught to believe, but it doesn't have any basis in law. Constitutionally, there's a separation of powers, but when it comes to First Nations, that doesn't actually apply from a court case point of view. The second part is the idea that somehow provinces aren't funded for these things. In the 1970s, when the tuberculosis hospitals were wrapped up and the funding was being pushed somewhere, all that funding actually went to the provinces. So since the 1970s, the provinces have been directly funded for Indigenous health. And in province by province, and I won't tell you the specific conversations I've had with people, there was literal conversations where medical officers of health were told by the ministries, we are pulling off of First Nations and providing no care anymore. And this happened in the early 90s. There was no legislation that was passed. There was no enabling legislation that existed. They just went ahead and did it. And because First Nations sat back and just let it happen, which makes a lot of sense when you look at the historical context of residential schools and how our communities were conditioned that the government gets to do what it wants, we have to sit back and let it happen. These are the reasons why infrastructure doesn't exist on reserve. The healthcare transfer actually enables every province to put on a per head basis how much money they should get. Indigenous peoples have been included in those calculations since the health transfer first started. So jurisdiction is a myth. Now the big challenge is how do you get groups who don't feel like they know how to interact with Indigenous communities to interact. And the big challenge that we've given out to organizations that have been in this area is actually the challenge to organize themselves. Organizations often think, what we want you to do is go into Indigenous communities and fix the problems. We don't want you to do that. We want to understand things from your point of view. So just within your organizations, organize. Within your scope of individuals, and you can use a lot of different scopes. We use one that came out from health, where we have patients, administrators, academics, healthcare providers, and policymakers. Split yourselves up into your own groups, organize yourselves, and then come to the table so we can understand where you're coming from. We can understand your part of the story. We can understand your priorities. And I think if you take that approach, it'll enable these organizations that have traditionally been very scared to get involved or very hesitant because we have all these beliefs that aren't necessarily true about Indigenous health, empowered to actually own their power. At the end of the day, we can have enormous impact in health. We know how far we've come from how things were, even from the beginning of my training to now. If we simply just bring in those same things, disparities will decrease by magnitudes that we can't even consider right now. Thank you.